Dear respected students, hello. Today's our lecture is pleura damaging syndrome, and before discussing of pleura damaging syndrome, particularities of this syndrome, I'd like to remind you normal anatomy of pleura and physiology. Pleura is a serous membrane covering the lungs, the inner surface of chest, mediastinum, and diaphragm. Pleura is a thin film that limits the enclosed tight space. There are two leaves of pleura, visceral and parietal. The pleural course can be well visualized if you immerse your hand in a bowl, and that part which is fit snugly around the hand, this is visceral pleura, in the root which goes to the parietal pleura, and between them you see space, pleural space. Visceral pleura cover each lobe and going inside formate the pockets or formate the folds, again go outside and go inside to the another lobe and cover whole lobes, whereas parietal pleura cover whole lung from outside. That's why visceral pleura size is much more than parietal pleura. Inflammation of the intralobar pleura we call the pericystitis. Pleura in the area of the roots of lungs, visceral pleura passes into the parietal pleura, and there are several parts of parietal pleura: mediastinal pleura, also costal pleura, diaphragmatic pleura, and here you see dome of pleura in which the apex of the lungs is located. Total area of serous membrane of pleural cavity is about 22,000 square centimeters. In place where parts of parietal pleura pass into each other, paired sinuses are formed. This we call it as pleural recesses or pockets. There are several pleural pockets or recesses: costodiaphragmatic, costal mediastinal, recesses and diaphragmatic mediastinal sinuses or recesses. They are needed to expand the lungs. When inhaling, the recesses are partially filled by the lungs, and then the pleural sheets that form there are separated from one another. When you exhale, lungs leave them, and in this case the leaves touch. Between the visceral and parietal pleura there is a narrow gap, which called the pleural cavity, which contain 1 to 2 milliliters, sometimes till 10 milliliters of fluid, which ensures the sliding of pleural sheets relative to each other during respiratory movements and their adhesion. Under normal condition, fluid is secreted by parietal pleura, which is vascularized by systemic capillaries. Average hydrostatic pressure in them is approximately 30 cm of water. From the pleural cavity, the fluid is reabsorbed by the visceral pleura, which is supplied with blood mainly by pulmonary capillaries. Average hydrostatic pressure in them is 11 cm of water. Certain amount of macromolecules and fluid is removed from the pleural cavity by the lymphogenous route. And also you should know the volume of secretion of pleural fluid by the parietal pleura and the volume of fluid which reabsorbed by the visceral pleura are equal. Also, you should know the parietal pleura secretes the fluid at a rate of around 100 milliliters per hour, and the visceral pleura can absorb it at a speed of up to 300 milliliters per hour. Lymphatic drainage from the pleural cavity is about 20 milliliters per hour. Surfaces of the visceral and parietal pleura turn into the pleural cavity are covered with mesothelium, a single-layer squamous epithelium with villi. Villis increase the surface of pleural many times over. Also, connective tissue basis of pleura is made up of elastic and collagen fibers. That's why in many cases damaging of connective tissues can cause damaging of pleura. In the pleura there are peculiar hatches or stomas, which are microscopic chambers bounded by thick collagen fibers and covered with a rich membrane and mesothelium. Due to this favorable condition are created for the absorption of fluid from the pleural cavity. A very important role has blood supply of pleura, but in clinical cases, mostly to understanding the accumulation of fluid in pleural cavity, it's most important to know blood outflow from parietal pleura and visceral pleura. From blood outflow from parietal pleura goes into the superior vena cava system, superior vena cava system, and to right side of heart, right atrium and right ventricle. Also, blood venous outflow from parietal or from visceral pleura goes to the pulmonary veins, pulmonary circulatory veins, which goes into the left side of heart, left atrium and left ventricle. Why I am saying this? Because in left side heart failure, also in right side heart failure, due to decreasing of blood outflow from parietal and visceral pleuras, may accumulate fluid in pleural cavity. Also, you should know, to understanding the clinic, pain sensitivity not present in visceral pleura, pain sensitivity present in parietal pleura. Also, you see pain sensitivity is present only in the costal and phrenic or diaphragmatic part of the parietal pleura. Chest pain with damage to the visceral pleura occurs due to irritation of receptors in the parietal pleura, and when the diaphragmatic pleura is affected, pain radiates to the cervical shoulder region on the side of lesion. It because of phrenic nerve. Also, if pleura contains dense network of lymphatic capillaries and plexus of lymphatic vessels, you see location of those lymph nodes. And main function of pleura is to participate under active breathing. And also you should know, in pleural cavity there are negative pressure -3 mmHg. And let's discuss syndrome. Syndrome of liquid accumulation of parietal cavity. Excessive accumulation of fluid in the pleural cavity leads to collapse of collapse of lungs, compression atelectasis develop, and a decrease in vital capacity cause restrictive respiratory failure develop. Large volume pleural effusion leads to compression and displacement sometimes of the mediastinal organs. As a result, we have hypoxemia and hemodynamic disturbances due to displacement of the heart and compression of the vena cava. There are two types of reasons of liquid accumulation in the cavity of pleural. May accumulate transudate, non-inflammatory fluid, or exudates, inflammatory fluids. Reasons for accumulation of transudates, they are heart failure, hypoalbuminemia, it's because of decreasing oncotic pressure, myxedema. Ascites may be associated with pleural effusion because fluid can move from the peritoneal space into the pleural space through diaphragmatic defects of lymphatic channels. And exudates may accumulate due to mycotic pleurisy, peripneumonic effusion, pulmonary embolism, metastatic neoplasm, Hodgkin's disease, and non-Hodgkin's lymphoma due to lymphatic obstruction, malignant mesotheliomas, and malignant tumor arising from the pleural mesothelium, we call it mesotheliomas. Systemic lupus erythematosus or drug-induced lupus-like syndromes, rheumatoid disease, acute pancreatitis, post-cardiac injury syndrome, for example, after myocardial infarction, developed Dressler syndrome, and uremia. Pleurisy is an infectious or aseptic inflammation of the pleura with the formation of fibrinous deposition on their surfaces and accumulation of fluid exudate in the pleural cavity. Pleurisy always is not an independent disease, but a syndrome that complicates the course of a number of diseases of the chest organs, lungs, mediastinum, diaphragm, and etc. Some common including systemic and other disease. That's why damaging of pleura always is secondary process as a complication of other disorders. By the presence of delimitation and localization, we recognize diffuse and limited pleurisy, and by location maybe is also diffuse and limited location. We have there are two types: apical, intralubar, or pericystitis, or diaphragmatic, or parietal, or costal, or mediastinal, and also diffuse mostly occur as a primary process. As a secondary process, when your patient has already one or two times before has diffuse pleuritis, and after diffuse pleuritis develop adhesion of pleural layers, which cause the limitation of accumulated fluid. We call it as localization or limited pleurisy. And a limited pleurisy, different location has different clinical appearance and course. Isolation of dry lesion of pleura or with effusion into the pleural cavity is conditional, since in principle there are stages of one process of pleural lesion. We have three different stages. First stage is always an inflammation of pleura or pleurisy develop from dry stages, and then after dry cause formation of effusion, and then after effusion, after reabsorption of exudate, formated adhesion and calcification of pleural layers. Clinically, manifestation of dry fibrinous pleuritis, manifestation combined with manifestation of the underlying disease, for example, combined with the pneumonia, the chest pain associated with the act of breathing. Main syndrome will be chest pain, aggravated by bending to the healthy side due to pleural distension on the affected side. Pleural friction rub, which does not change after coughing, will be heard by auscultation. Breathing is frequent and shallow, the lack of affected half of chest in the act of breathing. Also costal dry pleurisy, it's difficult to distinguish from intercostal myositis and neuralgia. If you are suspecting intercostal myositis and neuralgia, you should know that painfulness on palpation and increased painfulness when tilting to the painful side is characteristic. There is no pleural friction noise in myositis and neuralgias. And also you should know diaphragmatic and costodiaphragmatic pleurisy simulate acute disease of abdominal cavity organs, can lead to laparotomy. It's necessary to carefully listen to the lungs if an acute abdomen is suspected, to conduct X-ray or ultrasound studies. Location of thoracolgia indicates the area of defeat of pleura. Location of pain in shoulder region indicates defeat diaphragmatic pleura by a phrenic nerve. Characteristic decrease in intensity of pain in supine position on the sore side. You see our patient has a compulsive or forced position. He is laying on sore side, is when respiratory excursion on the affected side are reduced. Pain intensified when bending to the healthy side due to stretching of pleura. The intensity of pain depends on depth of breathing. Patient try to breathe superficially, limits the movement of pleural sheaths as much as possible. They bend to the affected side. Also in case of damage to the mediastinal pleura, there are no pain receptors in it, you remember, and in mediastinal pleura damaging region, you can only find equivalent of pain may appear. paroxysmal dry cough, persistent hiccups, sometimes maybe heart rhythm disturbances like arrhythmias or develop paroxysm, tachycardias, or extrasystoles. Laboratory signs are non-specific. All possible changes in blood, urine, and other tests are just signs of inflammation syndrome or signs of underlying disease. X-ray and ultrasound studies of the pleura, also non-informative, also may give us only underlying diseases signs. Diagnostic of dry pleurisy depends entirely on the professional skills of a doctor. There is nothing to confirm the presence of fibrin on the pleural sheets. Only during diagnosis, doctor should find out main diagnostic criteria. This is pleural friction rub by auscultation. Isolated dry pleurisy lasts from several days to 1 to 3 weeks. The pain disappears and the pleural friction noise disappear. In other cases, there is a progressive accumulation of pleural effusion and an effusion is formed in the pleural cavity. When dry pleurisy go to the effusion. Often with inflammation of the pleural layers, you can hear localized or diffuse pleural friction noise or pleural friction rub. Noise of friction of pleura is rough, scraping, resembles the crunch of snow under boots, is heard throughout the entire respiratory cycle, and its greatest sound occurs at the end of inhalation. The breathing of inhalation does not change after coughing. Sometimes the pleural friction noise increases when the phenendoscope or stethoscope is pressed on the chest wall. Manifestation of dry pleurisy are detected within a few hours before the transition of inflammation to the exudative phase, exudative pleurisy. Isolation of dry lesion of pleura or with effusion into the pleural cavity is conditional, since in principle there are stages of one process of pleural lesion, increasing the permeability of the capillaries of parietal pleura during the inflammation, also slowing down the reabsorption of fluid from the pleural cavity by the swollen visceral pleura, cause gradual accumulation of inflammatory fluid in pleural cavity and cause exudation process. Next process is exudation. Diagnostic and prognostic value is not only the presence or severity, but the rate of increase in the symptom of pleural effusion, acute onset with inflammatory lesion of the pleura, slow gradual onset of symptoms, tumor or congestive effusion. During a clinical examination of a patient, it's important to be able to distinguish sign of underlying disease and sign of actual lesion of pleura. Excessive fluid punctures the pleura and reduce friction between them. The pain decreases or stops after accumulation of fluid. Pleural friction noise disappear. Excessive fluid pushes the pleural layers apart and reduce friction between them, but appear another symptom, shortness of breath increase, a feeling of heaviness in the chest appear. The clinical manifestation of pleural effusion can vary within a wide range from none accidental finding during X-ray or section to extremely severe. Everything is determined by the amount of fluid, its localization in the cavity, the duration of the effusion or adhesion. On examination, the bulging of affected half of chest, the expansion of the intercostal space, it will be appear. You see our patient which is in sitting position and also see bulging on his right part. Against the background of shortness of breath, you also can find lagging behind of affected area. During percussion, dullness appear above the accumulates liquid within a volume of more than 300 to 400 milliliters. With a moderate amount of fluid in the pleural cavity, the upper level of dullness has the appearance of a resembling a parabola with a a vertex along the rear axillary line, which this parabola named by Ellis Damoso Sokolov line. An important sign in is the configuration of Damoso line. Parabolic, this curve shape give us information about fresh effusion, whereas pleural adhesion or old pleural accumulation fluid give us broken life of configuration. An increase in border by one rib in front correspond to an increase in effusion by 500 milliliters. Auscultatory sign of effusion into pleural cavity, weakening of vesicular breathing, bronchophony and vocal fremitus with a large effusion, and this accumulated sign are not determined. Dull sound area will be present upper border, dull sound upper border of Ellis Damoso line, the top point of which is located on the posterior axillary line, costophrenic sign. Also, we are recognizing here Garland triangles is a lung compressed by exudate, so part which is compressed by exudate, we have this triangle part. That's why we call it as Garland's triangles, is a lung compressed by exudate. Here a dull tympany sound is noted above it. The second triangle, this is Grok-Rahus triangles projected on the healthy side, and this represent by a dull sound zone which is associated with the displacement of mediastinum to the healthy side. During palpation, again, you can find out stiffness of the affected half of chest. Over the exudate zone, vocal fremitus weakened or not carried out. In the area of Garland triangle, the vocal fremitus increased because of formation of consolidation of lung tissue. Auscultation, vesicular respiration in the exudate zone weakened sharply in this zone, exudating zone, or is not heard at all. Above the border of the exudate, above the border which compressed region in Garland triangles, increase in bronchophony and as well as a bronchial shade of respiration, which is associated with compaction of lung tissue due to compression of lungs. In the case of significant accumulation of fluid in pleural cavity, patient may experience tachycardia, muffled heart sounds. And investigation methods. X-ray examination is very important. More than 100 milliliters of fluid may be detected by X-ray method. You see darkening or opacity of the posterior costal diaphragmatic sinus or indistinctness of the diaphragmatic contour, which an increase in the volume of effusion, the appear of the shadow with an oblique or horizontal level, you see. And also most important sign of significant pleural effusion is mediastinal displacement to the healthy side, to the fresh, this called as fresh effusion, where when effusion is combined with atelectasis or pneumocirrhosis or pneumosclerosis, mediastinum shift to the affected side. Also, we can use ultrasound investigation of pleural cavity, which may be detectable more than 50 milliliters of liquid. Diagnostic and therapeutic pleural puncture. It's a very important method to evacuate or exudate in case of effusion with detection of significant substances like microorganisms or tumor cells and etc. Also, we use thoracoscopy with pleural biopsy and bacteriological examination of pleural effusion and biopsy. Laboratory data reveal the cause mostly. We can provide blood tests where we can find out in case of pneumonias neutrophilic leukocytosis, shift leukocyte formula to the left side, also increase ESR. Also we can check the urine analysis, biochemical blood test. All these determine the cause of disorders. Study of the pleural fluid. Evacuation of effusion is performed by puncture in the 8th, 9th intercostal spaces between the posterior axillary and scapular lines in the sitting position on the patient, with arms bent in front into a clean, sterile container. The procedure is performed by a doctor. The entire amount of liquid obtained must be delivered to the laboratory. If its volume does not exceed 1 liter, with a larger volume, the last portion is delivered since it's richer in cellular elements. To prevent clotting and loss of cellular elements, anticoagulants or stabilizers like ETA, like heparins are added. There are types of research methods of fluid: pleural fluid, macroscopic, chemical, microscopic, bacterioscopic, and biological. We should define the character, detect the cellular composition, and we should provide identification of pathogens and detection of sensitivity to antibiotics. Also, we should recognize this accumulation fluid as transudate or exudate, inflammatory or non-inflammatory fluid. There are some differences between the exudate and transudate. Differences by containing total proteins. You know exudate much richer than transudate. Specific gravity also higher than transudate. Also lactate dehydrogenase containing, also containing of glucose level. For example, low glucose represent tuberculosis or tumor, rheumatic and parapneumonic pleurisy. Glucose less than 2.22 millimole per liter. This likelihood of the formation of empyema in high. No glucose, this is pleural empyema. In other variants of pleurisy, for example in transudate, glucose content in the exudate is usually equal to that in blood serum. There are types of exudates: serous, purulent, and purulent, petrificative, hemorrhagic, helical, chylus-like, cholesterolic, and eosinophilic. It depends on etiology. Serous, for example, transparent or cloudy, colored in yellowish tone of various intensity, mostly belongs to tuberculosis, syphilis, rheumatism, whereas the purulent sputum is represent pleural empyema. Putreficative sometimes maybe represent as gangrene of lung tissue. Hemorrhagic may occur in tumor, trauma, pulmonary infarction, hemorrhagic diathesis, or sometimes cholesteremic maybe mostly represent encapsulated effusion or cyst, and etc. Cytological study, for example, if in pleural fluid there are many RBCs, mostly represent hemorrhagic exudate. This, for example, thromboemboli or infarction of lungs. Leukocytes represent bacterial infection of pleura. Neutrophils also bacterial infection and exudate of pleura. Lymphocytes mostly prevail in tuberculosis pleurisy. Malignant tumor cells or atypical cells represent of oncological disease. LE cells, for example, systemic lupus erythematosus, and etc. And you see also accumulation of fluid on the left side. and you see also here is sinuses of all sinuses and the whole entire filled by fluid, and also you see the muzzle line. Next is the horizontal level of shadow indicates the presence of liquid and gas in pleural cavity at the same time. If formed at horizontal level, it mostly represents that doctor will remove doctor was removed the fluid, but also go inside the air, and air and fluid contain the formate this horizontal level of shadow. Here is total left lung pleurisy, exudate or transudate accumulation. This is mostly one side, this is exudate accumulation. Next is pneumothorax. Pneumothorax is a pathological accumulation of gas in pleural cavity leading to partial or complete collapse of the lungs. There are two types, open pneumothorax and valvular pneumothorax. Open pneumothorax, when you during inhalation gas go inside and during exhalation go outside, do not move and compress the mediastinum, whereas the valvular pneumothorax during inhalation air go inside, but during exhalation accumulated inside couldn't go outside and cause even displacement of mediastinum and cause a very severe complications, even shock condition. Etiological classification: there are spontaneous with rupture of the pulmonary alveoli, may be primary in the absence of clinically significant pulmonary pathology, and secondary complication of other pulmonary disorders. Traumatic with damage to the chest, penetrating chest injury or blunt chest traumas, and iatrogenic complication after a therapeutic or diagnostic interventions, like after puncture of the pleural cavity, after central venous catheterization, or after pleurosynthesis and pleural biopsies due to beta traumas, and etc. Clinically complaints, this is shortness of breath, chest of pain. It depends on severity of process. General examination give us pallor of skin and respiratory failure symptom like cyanosis and shortness of breath. Examination of chest, protrusion of thick hub of the chest in which there was an accumulation of air, smoothing of the intercostal spaces, tachypnea, lagging of thick area during breathing. During palpation, because of accumulation of fluid, will be soreness, rigidity of the affected half of chest, and vocal fremitus is sharply weakened or even not carried out. Percussion, this will be a loud tympanic sound. Auscultation, breathing is weakened, vesicular or not audible. Bronchophonia is sharply weakened or absent. With open pneumothorax, maybe bronchial breathing with a metallic shade. X-ray give us light pulmonary field without pulmonary pattern, and closer to the root, the shadow of a collapsed lungs. You see shadow of collapsed lungs. Blood test sputum, there will be no special changes. Here you see also, you see in one side, you see collapsed region, and another side takes working instead of compensatory working, we have increasing airness on one side. And this side you see accumulation of fluid, accumulation of gas, and which cause displacement of mediastinum to the left side. Also displacement of mediastinum to the left side, and you see accumulation of gas is pneumothorax. Also pneumothorax you see on the left side, you see, and also shadow of collapsed lung. I am finishing my lecture. Thank you for your attention.